All right, we will go to our next talk, which is implementing non-narcotic pathways in urologic MIS surgery. And our speaker is Dr. Eric Ballon-Landa, who's an assistant professor in the urology division. He did his undergraduate training at Williams College, just like our Dr. Swan did in the introduction last week. He completed an MPH at UCLA, did medical school at UC Irvine, urology training at UC San Diego, and then joined us recently. He's active at the VA. He's well published. He's an excellent clinician and teacher, and really an expert in minimally invasive approaches to urologic diseases. So Eric, Dr. Ballon-Landa, we look forward to your talk.
Thank you, Dr. Schulich, for the opportunity to speak today. I'm going to be discussing implementing non-narcotic pathways in minimally invasive urologic surgery. Our objectives are to evaluate the burden of narcotic prescription in urologic surgery, to identify the feasibility of non-narcotic pathways for minimally invasive robotic surgery, and finally, to summarize non-narcotic strategies that really can be implemented in multiple types of pelvic robotic surgery. I have no disclosures. I wanted to share about this topic today because I know that opioid prescribing is a priority to the department. Getting these, monthly emails for this excellent quality improvement project, which is focusing on reducing outpatient prescriptions of opioids. And so I wanted to share our experience regarding the inpatient management as well. Just to share, this is actually an old image from an old slide deck I gave a couple of years ago, which just shows that this has been a priority at the national level for many years now, and was brought initially to light by rising opioid overdose deaths, and additionally the lawsuits against the Purdue Pharma company, as well as the Sackler family specifically. Unfortunately, since that time, the number of opioid deaths has only increased. So that was around 2018, 2019. You can see that this line is the total number of overdose deaths secondary to opiates in our country. And recently, many of you probably saw the headlines that over 100,000 deaths in the past year were reached, which is a new and more grim milestone than we might have imagined. And why should we be concerned? Because multiple analyses have shown that the physician prescribed opioids can contribute directly to this problem. This is an analysis that was performed that showed that even for something as minor as an office vasectomy, nearly 8% of patients who were initially prescribed opiates at the time of their procedure reported persistent opiate use 90 to 180 days after the vasectomy. And this was significantly greater than the cohort of patients that was not prescribed opioids at the time of their procedure. This is a retrospective analysis in a single center, so of course maybe it's not as generalizable. But here you can see another secondary analysis that they just looked at the number of clinical encounters, clinic visits, ER visits after the procedure. And these, although some of them are trending upward, none of them were statistically significantly different, whether you were prescribed opiates during your procedure or not. And a similar story plays out at the national level. This is a study that looked at retrospectively an insurer-linked database. And here, these are 38,000, almost 39,000 patients who underwent urologic surgery and were prescribed an opiate at the time of their procedure and had been opiate naive before then. And you can see that basically down the line, there is significant numbers of persistent opiate use and chronic opiate use after their surgery. And these are defined as, persistent is defined as at least one prescription 90 to 180 days after the procedure. And chronic is even more stringent. That's actually 10 or more refills or 120 days of medications that were prescribed. And you can see that these are not insignificant numbers of patients. They also looked at who prescribed what numbers of opiates in this cohort. And so this waterfall plot shows that there's a wide variation in what physician prescribers give to patients after their procedure. So this 0 here is the median that's adjusted per procedure. And you can see that the number of opiates above the median was significant, and that the variation was significant as well. Here they split it up by the actual procedure that was performed, and you can see that also within the individual procedures there's a lot of variability. For reference, the median here for a cystectomy is 200 of total oral morphine equivalents. That's our standard way of describing this, which I'll get into in a minute. And 200 oral morphine equivalents, for reference, is 40 tabs of 5 milligrams of hydrocodone or 26 tabs of 5 milligrams of oxycodone. This may sound like a lot to many people in the audience. This is actually the standard when I started residency. I remember as an intern routinely prescribing 20 to 40 tablets of narcotics on discharge. And that wasn't that long ago. So we've made a lot of gains in a relatively short period of time. But here you can see even for vasectomy, which is a relatively minor procedure, these patients are getting about 30 tablets of 5 milligrams of hydrocodone. So I'd argue that's significantly more than what we're prescribing these days. And it turns out we were significantly overprescribing medications. So this analysis, which is a single center study done out of UPenn, shows that for the major urologic cancer surgeries, both minimally invasive and open, the number of opiates prescribed at discharge was, for all of the procedures, significantly more, and many times double or more than compared to what the patients actually took at home. So focusing on robotic and laparoscopic surgery, there are various sources of postoperative pain. The first is incisional pain, which is still present despite the small incisions. I remember a mentor telling me that, would you like to get stabbed and not have pain control after that? The second is abdominal insufflation, and that can cause nerve distraction injury, peritoneal pain secondary to distension, and finally diaphragmatic stretching and phrenic nerve irritation. There are various non-narcotic medication strategies, many of which will be very familiar to many of the individuals in the audience. Tylenol is the oldest, perhaps, 4 grams a day maximum. Obviously avoided in liver patients. Ideally, I prescribe this scheduled, not as a PRN dose, and I prefer to uncouple it from the narcotic. So I tend to avoid Percocet and Norco, which include a narcotic plus the Tylenol. NSAIDs, of course, limited to non-CKD patients. And then the neuropathic medications, so A2 delta ligands, gabapentin and pregabalin. These focus on treating neuropathic pain. One of the main side effects of gabapentin especially is drowsiness. And one way around that side effect is to prescribe it to patients to take at nighttime so that the drowsiness is less of an issue and perhaps a benefit. And then finally, there's local analgesia options. Exparel is the liposomal, very long-acting bupivacaine. That's something that we've used with some success. It is difficult to obtain simply just because of the cost. And it is a little bit finicky in terms of the administration. You need a large bore needle, and it doesn't diffuse in the tissue the same. So you have to deposit it in essentially aliquots along the incision. And I think the pain benefit may not have at this point outweighed the cost, and so it's not as widely used. The transversus abdominis plane block is something that we do perform and can be performed laparoscopically or robotically. We'll get into that a little bit more. Finally, just a little caveat about tramadol. I call it a dirty drug. This is a narcotic. It's actually an opioid with very weak receptor binding. And so the equianalgesic dose of tramadol is 100 times that of morphine for that reason. And the effect is mediated by one of the metabolites that requires P450 metabolism for the analgesic effect to take place. And that requires the CYP2D6 enzymes. However, 3 to 10% of patients do not have CYP2D6 activity, and these patients will have no metabolite and therefore will achieve no pain control with tramadol. And conversely, there are ultra metabolizers of CYP2D6, and these patients may require significantly larger doses of the medications to get the same analgesic effect. Finally, there are many side effects: respiratory depression, which is just like opiates, seizures and serotonin syndrome, which is due to an SNRI activity, and hypoglycemia. And so my feeling is you don't necessarily know if you're getting the pain control that you're aiming to get with this drug. And additionally, you don't avoid many of the side effects, and some of them are even worse. I've had a colleague who had a patient develop serotonin syndrome on the floor. And finally, tramadol is equally or even perhaps more addicting than opiates. This study was elegantly performed. They used the similar insurer-linked database, and they looked at the cohort of patients who were prescribed opiates, opiate-naive patients prescribed opiates at the time of surgery. And so you can see that the reference here is actually patients who are prescribed sort of the standard short-acting narcotics, hydrocodone, oxycodone. And compared to those patients, patients who are prescribed tramadol only had a higher, significantly higher odds ratio of developing persistent or chronic opioid use after surgery. And these chronic and persistent definitions are essentially the same as those I described earlier. The authors for this study concluded that maybe the difference wasn't so clinically significant, but that they are at least equally addicting compared to the standard narcotics. And so for our non-narcotic pathway, I kind of put it in quotes, you'll see why. I'll just describe kind of how we do it. This is for our robotic-assisted laparoscopic radical prostatectomy patients. Intraoperatively, we perform a tap block laparoscopically at the start of the case, typically aiming for about 20 to 30 mils of bupivacaine. And there's sort of two ways to do this. One is just sort of focusing on the actual port sites. And then the second is to go kind of along the lateral aspects of the abdominal wall and perform a more proximal block. I typically do the latter, but the importance is to be in the tap plane. We always give Toradol at the conclusion of the case, and except for in the cases of CKD patients, of course. And then postoperatively, we always schedule Tylenol. We have an IV option at the VA, so if the patients are PO intolerant, we don't hesitate to offer IV. Toradol is scheduled or is written as a PRN for mild pain. So that would be the first PRN medication that they would receive if they develop pain. We also perform an ERAS protocol like many of our colleagues and many in the audience, I really believe that early ambulation is one of the main mediators to relieve the abdominal distension related pain from the laparoscopic approach. They get a regular diet, they don't have a drain, which is associated with worse pain outcomes and otherwise no clinical change. And then finally, we use an oral oxycodone as a 5 milligram breakthrough only. Here are the oral morphine equivalents. So this is sort of the standard way of reporting narcotics. You can see the IVs are more potent and therefore they have a higher oral morphine equivalent compared to PO. And then just to point out here that hydrocodone is a 1-to-1 ratio, oxycodone is 1 to 1.5, so it's 50% more potent. And then tramadol is the other direction, 100 to 1, so 100 milligrams is equivalent of 1 milligram of morphine. So this is our experience with I call it minimal narcotic RALP. We, at my prior institution, have made a practice change that we sort of observed and tabulated, as I'll show. And then since I came to the VA, we've continued that experience. So our initial experience at my prior institution, I'm sort of calling it a case control study. 27 patients, these were consecutive RALPs that were performed, 17 controls, which is the initial sort of standard pathway, and 10 cases, which was the sort of non-narcotic pathway after we made a management change. For all these patients, we evaluated their inpatient narcotic usage and pain scores during the entire inpatient hospitalization. One patient in this cohort reported a history of narcotic use before surgery. This was in the intervention group. And then we looked at who received non-narcotic medications. We found that 1 out of 17 in the control group received lidocaine patches, and 10 out of 10 in the intervention group received some non-narcotic medication, 80% IV Tylenol, 80% IV Toradol, and 50% lidocaine patches. Here are our initial outcomes. So the oral morphine equivalence in the standard group was almost 25 milligrams with a mean pain score of 3.3. And then in our non-narcotic group, we more than halved the oral morphine equivalents during their hospitalization, down to almost 10, and the mean pain score actually went down 2.5. The difference between the two as far as the oral morphine equivalents consumed didn't reach statistical significance. However, the small number of patients, I sort of intuited that this was sort of approaching significance. The pain scores did not appear to be significantly different. Finally, we looked at our VA experience. So we looked at patients over the past year. This was 22 patients, almost 20% of which had history of CKD. Another 20% had a history of chronic opiate use. None received a blood transfusion, and 86% received IV Tylenol, and 81%, almost 82% IV Toradol. The number of non-narcotic medications that was prescribed, the median was 2, and the number of PRN oral narcotic doses for their entire hospitalization, a median of 1, and no IV narcotic doses. And so when we added up the total oral morphine equivalents that were consumed, it was 7.5 milligrams was the median. You can see the range was up to 20 for the 75th percentile. But 7.5 oral morphine equivalents is equivalent to 1 tablet of oxycodone, 5 milligrams. So we feel pretty good about that. So in conclusion, we can minimize perioperative narcotics. Postoperative prescriptions, as we've seen in these various studies, do lead to chronic opioid use in a subset of these patients. And so limiting that is very important. I call it a minimal narcotic management is feasible for major laparoscopic abdominal surgery. We find that the multimodal strategies really limit the opiate requirement and that the pain scores are similar. I should say we didn't report the pain scores for our VA experience just because we found that the reporting of pain scores was quite variable, and we didn't trust that our data was good enough to report. And then finally, patients can continue multimodal analgesics at home. So I make it a point to write a prescription for Tylenol and or ibuprofen on discharge for these patients. And I think even though many of them may already have those medications at home, it sets the tone that this is the part of the medication pain control strategy for you to continue at home. And then, and additionally, it's allows them to use the narcotic prescription for breakthrough pain only. Many patients may not have Tylenol or Motrin and may not stop by a pharmacy on the way to home. And so maybe they get home and they have pain and all they have is the 5 to 10 tabs of oxycodone that you've written them. A few caveats. Robotic prostatectomy is transitioning to an outpatient surgery, and in fact is already performed as such by many of my colleagues over here at the university. And so inpatient, as we say, inpatient narcotic management may be a thing of the past increasingly. The other one to mention is that the opiate prescribing practices have decreased significantly. So many of these studies that I was reporting, they were performed in a time when many more narcotics were prescribed than what we currently send patients home with. And so that may have an impact on the risk of persistent or chronic opiate use after surgery. But we don't really know the answer yet. And then finally, the intraoperative and in-hospital administered opiates are excluded from many of these studies. And so we don't really know what the impact is of somebody getting these narcotics while they're under our care directly. But I would argue that it sort of sets the tone for the patients. And so if you sort of emphasize all of these non-narcotic pain medications while they're in the hospital under your care, it just stands to reason that they would continue that sort of practice when they are home by themselves. And finally, our goal is not to achieve this as a new pain scale. As we saw, that the pain scores did not increase with these new strategies. And so we still can treat patients' pain. A couple areas of inquiry to continue. The first is, what is the patient perspective? All these studies that I presented were either retrospective analyses or physician-directed. There are others that have looked at basically physician polls, but none have really examined the patient perspective. Of course, the opioid overdose epidemic is very much in the national consciousness now. And so patients are really important stakeholders, but they're also going through something that is perhaps a first in their life and relatively unique. And so they also should have a say. Second, sort of already alluded to this, but the surveillance for post-surgical opioid usage. We should continue to do that in our current practice, where we are sending patients home with many fewer narcotics than what we previously would have done. And also to ensure that the, to see that the opiate levels of prescriptions have gone down. Certainly that's been the case in our department based on the monthly emails and increased compliance with the opiate prescribing on discharge, but that may not be the case on a national level. And then, of course, ideally, we would have randomized multi-center trials to further delineate these questions. The difficulty of this is sort of the horse has kind of left the barn already. So I don't think you would find many prescribers that would be willing to go back to prescribing patterns from the early 2000s or even 2010s. And just to acknowledge, Dr. Chua's, one of our excellent interns, helped me with the data collection and analysis for the VA cohort. Much appreciated to him. And Granville Lloyd, my partner at the VA and robotic mentor, who was doing many of these things before I arrived. And so I can't take much credit without him. He's responsible for at least half of it, if not more. Finally, just thank you to all our wonderful residents and to Dr. Meacham and Dr. Wilcox and all of my mentors in the faculty who have been so wonderful here to me. Thank you very much.
So, Dr. Ballon-Landa, Eric, that was a great talk and very timely, especially with all the news flying around with the opioid overprescription. And, I trained obviously a couple of decades ago, and I remember being chastised for not writing enough narcotics. I had written a patient for 30 days of narcotics on discharge, and the attending wanted 60 days so that they wouldn't call, back to the clinic or call back to the office. And I am sure that behavior was rampant and the norm. And I think that helped drive some of the major issues that we're seeing now. Our department, and a lot of this has been led by our residents. And you mentioned Laura, has shown that if we actually discuss this and educate our faculty and staff about this, we can have a very positive impact. So thank you so much for summarizing this for us. I think Dr. Wilcox has his hand raised.
Eric, thank you very much for that excellent talk. And as Dr. Schulte said, very timely. I just had a couple of questions. How has that changed your pre-op counseling of patients now? Do you stress that they probably won't need opioids afterwards? And secondly, have you changed your electronic patient record order sets to sort of nudge faculty and residents in the right direction and created limits on what they can prescribe?
Yeah, good question. So the counseling really has not changed significantly. Most all of our patients are discharged on post-op day one. That was always the case at my prior institution as well. Obviously, it's moving towards outpatient discharge, but I find that by emphasizing the negative aspects of narcotics, like constipation, which is a trigger of much pain itself post-operatively, that patients are increasingly on board with sort of a minimal narcotic approach. But I don't spend a lot of time counseling them about it preoperatively. I would say postoperatively it comes up, but it's more to emphasize the sort of non-narcotic strategies. And then as far as the electronic medical record, you may know the VA has a quite outdated electronic medical record, so that doesn't include order sets or anything like that. So we don't have it there. We have it sort of involved in our kind of standard resident pathway. But at my prior institution, we did actually make changes. We had a post-operative, basically RALP order set that had included narcotics, and we basically removed the narcotics except for the breakthrough, like severe pain. And that made it easier to basically implement that change, because you had to actively choose to order a medicine that was not in the order set in order to kind of give more narcotics.
Thank you.
Okay, congratulations. I think we're at time. I know we're at time. And we had two wonderful talks this morning, very informative. I wish everyone a great and productive week. Thank you.